Pleasure to welcome all the respected faculties, the Aora fellows, and all the regional anesthesia enthusiasts who have tuned in for today's session. So, today's class, we are going to talk about peripheral nerve stimulators. Although, with the incoming of ultrasound, this has become a lost art, but still, peripheral nerve stimulators they form the backbone of the regional anesthesia practice, and it is a must-have skill for everybody who is practicing regional anesthesia on a day-to-day basis. So I request everyone to actively participate, ask questions, share their experiences with the use of peripheral nerve stimulators in their practice. And we hope to look forward to a session of good learning today's evening. So our presenters for today's evening, we have first Dr. Manjesh S, who would be talking about the principles of PNS. Manjesh is a fellow of Manipal Hospitals, Old Airport Road, Bangalore. Next, we have Dr. Nara Meera from AIG Hospitals, Hyderabad. She would be talking to us about peripheral nerve stimulator machine setup, preparation for block and demonstration. And last, we have Dr. Radhika Ganesh from Children Anesthesia Services, Mumbai. She would be talking to us about limitations and pitfalls of peripheral nerve stimulators. I would give a brief introduction about our moderators for the evening. First, we have Dr. Bharti Adya ma'am. Ma'am is a chief consultant anesthesiologist from Sancheti Advanced Orthocare Hospital, Pune. She has worked as in charge of ICU for 8 years, active member of trauma team involved in the management of polytrauma patients. Ma'am has special interest in anesthesia for corrective surgeries for spinal deformities, minimal invasive surgeries, joint replacements, and ERAS protocols. Her special interests are in RA techniques and pediatric anesthesia. Ma'am has been a faculty at various national conferences. Also, she has various publications in national and international journals. Ma'am is also AHA certified instructor for BLS, ACLS, and PALS courses. We are also delighted to have with us today Dr. Anupama Tripathi Shrikant ma'am. She's a senior consultant anesthesiologist at Manipal Hospitals, Old Airport Road, Bangalore. Ma'am has made multiple presentations at various conferences. She is ex-HOD at Malti Manipal Hospital. She is also involved in anesthesia for Smile Train program for more than 500 cases of cleft lip and palate surgeries. Also, ma'am has initiated mentoring for RA fellowship program under Aora at Manipal Hospitals, Old Airport Road. We have with us today Dr. Anita Nileshwar Shinoy, ma'am. Ma'am is MD and Fellow of the Royal College of Anesthesiologists. Currently, she's a Professor of Anesthesia at Kasturba Medical College, Manipal. She's launched the Indian Journal of Respiratory Care and was founding chief editor and continued as the same for this journal for last 10 years. Ma'am has more than 50 papers in both national and international journals and chapters in various books. She's also co-editor of Manipal Manual of Surgery. Her areas of interest are difficult airway, regional anesthesia teaching. So we have our first presenter of the day today, Dr. Manjesh S. I would like to request Dr. Manjesh to kindly share his screen and start presenting.
Thank you, Shruti.
Thank you, ma'am.
Good evening to all the faculties and dear fellows. Ma'am, can you see my screen?
Move it to slideshow. Put it. Yes, we can see, but please put it to
Yes.
slideshow. Yes.
Yes.
We can see. Go ahead.
Yes. Good evening to all the faculty. Today we'll be discussing about peripheral nerve stimulator, and I'll be talking about principles of peripheral nerve stimulator, which the other parts will be covered by my fellows, like colleagues. So, coming to the principles, any regional anesthesia techniques which aims to locate a nerve or a nerve containing compartment, and we deposit a local anesthetic around the nerve or within that compartment to block the nerve conduction. So, various techniques that were used were initially there was a paresthesia, eliciting the paresthesia, and then came the nerve stimulators, and the recent advances now is using the ultrasound. So coming to the history, in 1780, Galvani was the first to describe the effect of electrical nerve stimulation. And in 1928, Kulemkampf described the brachial plexus block. So, and coming electrical stimulation to locate the brachial plexus was first explained or described by Perthes, but it was a crude method, and hence later came the modifications. In 1955, Pearson demonstrated that motor nerves could be located by electrical stimulation with an insulated needle. In 1962, Greenwald and Denson devised a portable trans-isotorized nerve stimulator, which stimulated further use of nerve stimulators usually being used. And in 1969, Wright reported that block-aid monitor for nerve blocks, which popularized the technique, making it more feasible. And in 1973, Montgomery and colleagues demonstrated that non-insulated needles require significantly higher current amplitude as compared to the insulated needles. And in 1984, Ford and colleagues suggested the use of nerve stimulators with a constant current source. Coming to the basics of nerve, like that is electrophysiology. So the concept of membrane potential, it is a difference in electrical potential between the interior and the exterior of a biological cell, and all cells will have a resting membrane potential, which is relatively static membrane potential of quiescent cells. And when there is a ionic movement between the interior and exterior of the cell, there will be a depolarization or hyperpolarization based on the movement of the cell, during which the cell undergoes a dramatic electrical change, giving rise to an action potential. So action potential, it is a very rapid change in the membrane potential that occurs when a nerve cell membrane is stimulated. A decrease in electrical potential difference to minus 55 millivolts leads to an action potential, that is the depolarization. The resting membrane potential of the nerve is usually about minus 70. So when it reaches minus 55 millivolts, it will give rise to an action potential. Coming to the concept of current intensity, it is a measure of stimulus strength. It is the flow of electrical charge used to depolarize the nerve and subsequently produce a motor response or a twitch. So the total charge applied to excite a nerve is equal to the product of intensity of current, that is I, applied and sufficient duration to which it is applied. So it is given by the equation Q, that is the uh, total charge applied is equal to the intensity of current times the duration of to which it is applied. So it is governed by, according to Ohm's law, nerve stimulators maintain a constant current by raising or lowering the voltage in response to the changes in the resistance, which we'll talk about later. And it can be illustrated by the stimulus strength duration curve. This is the stimulus and duration times curve, which shows a different duration on the intensity of the current for motor nerve and the sensory nerve. And it is it has two basic concepts, that is Riobase and Chronexy. The stimulus, we'll talk about it now. The stimulus needs to be strong enough and it needs to be applied for a sufficient time to produce an action potential. The minimum current required to initiate an action potential in the nerve is called Riobase, below which the current cannot initiate the impulse, and even if it is applied for a prolonged duration. So Riobase is the minimum current required to initiate an action potential. And chronexy, it is a duration or the length of the time the current must be applied to the nerve to initiate an impulse when the current level is twice the Riobase, that is 2 times the Riobase is chronexy. And the chronexy varies in different nerves depending on their sensitivities and their refractory period. For example, in unmyelinated nerves like C fibers, chronexy time is zero point 0.4 milliseconds, whereas in myelinated A alpha, it is 0.05 to zero point 0.1 milliseconds. Nerves usually have the same Riobase, but chronexy varies. Larger the nerve fibers, shorter the chronexy. That is, if the nerve is, if the dimension of the nerve is larger, the duration required to excite is like shorter. That is, the chronexy is shorter. Chronexy values provide an indicator of relative excitability of a nerve. It's possible to stimulate a motor nerve, but not sensory nerve, using a current of smaller crown axis, which we saw in this graph. This shows that motor nerve can be excited easily with a zero point 0.1 milliseconds and a crown axis of zero point 0.1. But the same sensory nerve, to stimulate the sensory nerve, we'll need a longer duration of current, that is almost 1 millisecond. So coming to the threshold current is the lowest current which produces a motor response, and a value between zero point 0.3 to zero point 0.5 milliamperes has been suggested to ensure a successful block in any regional anesthesia using a peripheral nerve stimulator. But a value of current cannot be taken as reliable indicator of the distance of the needle from the nerve, because it depends on the needles that we use as well. Coming to the concept of frequency, it is a number of repeating events per unit of time, or the number of stimuli applied every second. A stimulation of 1 or 2 hertz appears optimal for nerve localization. 1 hertz is used commonly, we use is 2 hertz, which allows for faster needle manipulation. And in a newer sense peripheral nerve stimulators, 3 hertz is also available. Higher frequencies gives rise to greater discomfort to the patient. Hence, low frequency of risk nerve penetration and injury. Lower the frequency, lower the risk of nerve penetration and injury. Coming to the quality of stimulation, it is guided by three main concepts, or that is the polarity and the distance of the needle from the nerve, and the impedance or resistance, that is the interaction at the tissue interface. Coming to the concept of polarity, most modern peripheral nerve block stimulators have the cathode being as a needle. That is, the tip of the needle will be negative. If the needle is positive, then the nerve will get hyperpolarized and a larger current will be needed to depolarize the nerve. This is the pictographic example of for polarity. So the needle tip, if it is cathode, and it will give rise to a motor response with the less duration or the less current intensity. But if the same needle tip is anode, it will not give rise to a motor response at that same current intensity. Coming to the distance, so distance current relationship, the relationship between the threshold current and the distance from the nerve is governed by Coulomb's law, which is given by the equation is equal to constant k times minimal current over square of distance from the nerve. That is, minimum current required to stimulate the nerve is directly proportional to the square of its distance from the nerve. That is, q is directly proportional to r square. Hence, this gives a concept that at a lower current intensity, the nerve will only be stimulated when the needle is very close to it. And coming to the concept of impedance, it is a resistance of the circuit formed by the nerve stimulator and needle tissue characteristics of the patient, the grounding electrode, and the cables. So usually the grounding electrode we use is the ECG electrode. So the resistance of the needle tip and the electrode to skin impedance have the highest impact. So impedance of the needle tip depends on the geometry and insulation of the needle tip, while electrode to skin impedance depends on the type and hydration status of the skin and the quality of ECG electrode used. And the nerve stimulator, which with constant current is required to compensate for a wider duration. So the stimulating needles, initially there were needles are insulated and only the tip will have the electrical activity. An insulated needle has the whole of the shaft as it is insulated except for the tip. So this gives the concept that if the tip is insulated, we'll need a lesser current, or the nerve can be uh,
Your voice is breaking up, Manjesh.
Like we can elicit the response if the
Manjesh,
needle
you
is
will have
uninsulated
to
motor.
again discuss the
Ma'am,
stimulating needle. Your voice was not audible. You have to go to the
hello,
insulating needle slide and you have to discuss it again. Yeah.
hello.
Am I audible,
Now,
Manjesh? Yeah. So you have to go to the
now,
insulating
ma'am,
needle slide. Yeah. You have to discuss it again.
hello, ma'am, here, hello.
Yes, Manjesh, you are having network
Am I
issue.
audible now?
Now you are audible. You have to
Hello.
go to the stimulating needles. Yeah, to this slide. Please discuss this again.
Yes, ma'am. So I'll continue, ma'am. I
Manjesh,
I
your
can't hear.
voice and screen both are gone. Yes, now you are visible, but
Hello,
your voice is breaking. Can you hear us?
ma'am. I can
Please
hear,
check
ma'am.
your yes.
Am I
Please
audible?
check your internet connection because your connection is absolutely shaky. Please check.
Yes, ma'am.
You have to share your PPT also now, Manjesh.
Hello, ma'am. Hello.
Yes, Manjesh, share your PPT.
कौन किया था? Ma'am, I will just call him to get connected. Just 2 minutes.
Go ahead, Sangamitra.
Ma'am, his phone is switched off. I think maybe.
Not picking up. He's not picking up mine
I'll
also.
I'll try his number, Sangamitra. I'll just try.
Okay, ma'am. Okay.
We can move to next presentation, Sangamitra.
Right, sir. Right, sir.
We got him, I
Hello,
think.
ma'am.
Yeah,
Am I
Manjesh.
audible? No.
Yeah, you are very well
Uh,
audible now. Your network seems good.
uh,
Can you reshare
uh,
your PPT, please?
Sorry for the inconvenience.
Ah, it happens. It happens. It's okay.
So the as we discussed, the stimulating needles and the tip. So using a the equipment needs to be checked. That is, it has to be set to a desired initial current of 1 to 2 milliamperes and a pulse duration of 0.1 milliseconds with the frequency of 2.
Okay, Manjesh, can you make it full
The
screen?
needle is connected to the cathode of the machine, and that is and the anode is. Hello, ma'am. Hello,
Manjesh, full screen.
ma'am. It is full screen. Like
Slideshow,
for me, it is
slideshow.
full screen.
Slideshow.
Slideshow.
Yeah. Oh,
Slideshow.
yeah. Thank you.
Yes, sir.
So also we wanted him to start with the
Sir.
needles, right? Restart from the needles.
Yeah. Manjesh, can you go on to the insulating needle slide? A slide just before this one. Yes. Can you start from here, please?
Yes, ma'am. I'll go back to the needles. Yes, ma'am. So coming to the stimulating needles and comparing this, so intensity of current and the duration that is required to stimulate or excite the nerve is less compared to the non-insulated needle. Uncoated needles will require a stronger stimulating current to elicit the same response as compared to the insulated needle. So coming to using a peripheral nerve stimulator for a peripheral nerve block, the equipment needs to be checked, and it is set at a desired initial current of 1 to 2 milliamperes with a pulse duration of 0.1 milliseconds and a frequency of 2 hertz. So the needle is connected to sure that the circuit is complete as soon as the needle is motor which is obtained. The current is then between 0.3 to 0.5 milliamperes is accepted as an ideal threshold current. So below 0.5 milliamperes, it has been shown to give a high success rate. So below 0.3 or 0.2 may mean that the needle tip is very close to or in the nerve and should be withdrawn before the injection. Coming to the important points before concluding, a peripheral nerve stimulator is a useful aid to locate nerve for peripheral nerve blocks. The usual peripheral nerve settings are a pulse duration of 1 millisecond, 0.1 with a frequency of 2 hertz. Threshold current of less than 0.5 milliampere usually results in a successful block. A current less than 0.3 with increased resistance on injection or pain on injection may suggest that the needle is intraneural. So I'll conclude my talk on the principles of peripheral nerve stimulators with this slide.
Good.
Hello.
It was a good presentation, Manjesh. It was a good presentation.
Thank you, ma'am. Thank you.
Hetal sir will have discussion at the end of all three topics.
I think Sangamita will finish off the topic and in the
Yes.
end have a discussion.
Yes, ma'am. Yes. So, Dr. Meera, will you please share your PPT?
Yes, ma'am. Am I audible?
Yes, doc.
Uh, Good evening, everyone. Today, I'm Dr. Meera Narra, fellow at AAJ Hospitals, Gachibowli. My moderator for today's topic is Dr. Anita ma'am, and my program director is Dr. Sunil T. Pandya sir. And today I'll be discussing about PNS machine setup and preparation for block. So first we'll be discussing about induction and block room. So regional anesthesia is ideally performed in a designated area with access to the equipment for time efficient and safe practice of peripheral nerve blocks. We need adequate space and proper lighting, equipment, drugs and material to perform blocks. This is the area which we usually use to perform the blocks in our institution. We need full patient monitoring, a source of oxygen, equipment for emergency airway management, and things for positive pressure ventilation and access to emergency drugs. So coming to patient monitoring, we need to monitor pulse oximetry, NIPP, ECG, and capnography. Uh, the suggested organization of nerve block card contains emergency equipment like laryngoscopes, assorted blades, Megill forceps, stylets, oxygen masks, ET tubes, LMAs, and everything. And coming to medications, sterile saline, propofol, long and short acting local anesthetics, emergency medications, and syringe labels. And all the needles like stimulating and non-stimulating needles, catheters, and spinal needles and general equipment like syringes of all sizes, ECG leads, pressure monitors, skin adhesive and catheter securing systems, lubricating gel and sterile gloves. And we need sterile sets, sets that include sterile trays, sponges and transducer covers. And the suggested emergency drugs required during last hour, intralipid 20%. It is recommended to have an intralipid 20% in the emergency cart in the block room. And seizure control medications like midazolam, propofol, and muscle relaxant like succinylcholine. And if for cardiac arrest, and we need epinephrine, amiodarone, etc. Atropine, ephedrine, and phenylephrine also has to be kept ready. And first coming to documentation, we need to take up written and informed consent and check if the coagulation parameters are okay. And we have to check if the ultrasound is working well. And we have to uh, uh, document about the medication that we are administering, and we have to follow the sterility and all the monitors that we have monitored and all the equipment that we have used and the amount of drug we have given and also any adjuvants that we have used. And we should also document the especially the time and the date. And for setting up a peripheral nerve stimulator for peripheral nerve blockade, we need pre-procedure checks. Like we should check if there is adequate battery power and all the functioning cables and connections of functioning and all the connections properly placed and the machine displaying actual current flowing through the patient and the display clearly visible to the operator. And needle and current adjustments, like either the needle should be moving or the current should be changing, and we should never change both at the same time. And the medications, we should always avoid the muscle relaxant in order to elicit the response, and also considerate about the patient comfort. We have to be carefully control the needle advancement speed to stimulate motor fibers without pain. Set PNS pulse duration to 0.05 to 0.1 milliseconds. And injection technique, the initial injection should be done very slowly. So we have to use only a nerve stimulator specifically manufactured for nerve blocks. And before starting the procedure, we have to check for proper functioning of the nerve stimulator and connecting cables. And we have to select between 0.1 and 0.3 milliseconds of pulse duration for most purposes. And always use insulated nerve stimulation needles and use high quality skin electrodes with a low impedance. This is the device that we have recently started using at our institute. This is a StimPod NMS 450X by X7. This is a device which can be used for either neuromuscular monitoring and peripheral nerve stimulation as well as for nerve mapping. And the parts are, this is a LCD screen which has a touch screen, and these are the, one second, sorry. And the control buttons, the power button, and this is the output port to which we can connect the various lead wires. And this is the charger first for the device. And this is the electromyography sensor module. And this is the circuit we use for the PNS and nerve mapping. And basic settings and implications. First is current intensity or amplitude. We have to use low current intensity nerve stimulation, that is 0.5 milliampere with ultrasound guided nerve blocks, that is dual guided. And it is not necessary to change the current intensity during the procedure. And coming to pulse duration or pulse width, between 0.1 and 1 milliseconds, because motor nerves are stimulated more easily with the current of shorter duration because their chronaxy is very less, while the sensory nerves require a longer stimulus duration because of the higher chronaxy. And coming to stimulus frequency, between 1 and 3 Hz, meaning 1 to 3 pulses per second. At 1 Hz, the needle must be advanced very slowly to allow time for the delivered pulse to evoke a motor response, whereas at 2 Hz, the needle can be advanced twice the speed. And coming to needle types, there are insulated and non-insulated needles. Insulated needles are Teflon or silicon coated with uncovered tip. They have maximum current density at the tip, and the position of the tip correlates to the target, and the current intensity can be at 0.2 to 0.5 milliampere, and it results in usually higher success rate. Coming to non-insulated needles, they transfer the current throughout the entire length, so there will be a large conduction area, and it is difficult to localize the target and nerve, and we need higher current for the stimulus because it is getting dissipated, and the success rate would be much lower when compared to the insulated needles. And these are the recommended gauges and recommended lengths of the Stimuplex needles for different types of blocks. For interscalene block, it is recommended to use 25 to 22 to 25 gauge with the 50 to 80 mm, and supraclavicular 22 to 25, axillary block 22 to 25, and for deeper blocks like lumbar plexus block, 18 gauge to 21 gauge with 80 mm to 100 mm length needles. So coming to electrode localization, the stimulating needle and return electrodes are the electrodes used during the peripheral PNS. The orientation of these electrodes, negative and positive, affects the current necessary to elicit a motor response. The negative electrode cathode should be connected to the needle, while the positive electrode anode should be attached to the patient's skin. And the current flowing from the needle acts as a cathode. It alters the resting membrane potential of the cells nearby, which leads to nerve depolarization and generation of action potential. And the return electrode is not important because it can be placed anywhere on the skin when using a constant current output stimulator, and the circuit should be complete. For using a peripheral nerve stimulation as a localization tool without ultrasound guidance, we have to set an amplitude of 1 milliamperes in the starting for most superficial nerves. And for deeper nerves, it may be necessary to increase the initial current between 1.5 to 3 milliamperes until a motor response is elicited at a safe distance from the nerve. So after obtaining the sought after muscle response, the current intensity amplitude is gradually reduced and the needle is advanced slowly further. And if you too rapid advancement may miss a response between two stimuli. So advancement of needle and current reduction are continued until the desired motor response is achieved with a current of 0.2 to 0.5 milliamperes. And once the needle is positioned to obtain a motor response at around 0.3 milliamperes and pulse width of 0.1 milliseconds, 1 to 2 ml of local anesthetic is injected as a test dose, which abolishes the motor response. Block demonstration. This is a case of 41-year male ASA1 with the right shaft of humerus fracture posted for open reduction and internal fixation. So after explaining the procedure to the patient and obtaining informed written consent, standard ASA monitors were connected and IV access was secured. And we have given injection midazolam 2 mg IV for anxiolysis, and patient was positioned appropriately and aseptic precautions were followed. Under ultrasound guidance, the brachial plexus at interscalene level was identified, uh, and a peripheral nerve stimulator was used as an adjunct for the confirmation. The initial current was set at 0.5 milliampere, which elicited the visible motor response, that is shoulder twitch, indicating close proximity to the nerve. The current was then reduced to 0.3 milliamperes, at which the motor responses disappeared. This suggested that the needle was near the nerve but not intraneural, as a twitch at very low current may indicate proximity. So the current was subsequently increased back to 0.5 milliamperes and the motor response reappeared, confirming appropriate safe needle position. So at this point, local anesthetic was injected, following which motor response gradually disappeared. And coming to common problems encountered during localization of peripheral nerves and the troubleshooting. So when the problem is that the nerve stimulator does not work at all, check and replace battery and refer to operator's manual. And if the nerve stimulator suddenly stops working, check and replace battery. And if no motor response is achieved despite the appropriate needle placement, check connectors, skin electrode, cables, and stimulation needle for an interrupted circuit or too high impedance. Check and make sure that current is flowing, and do not disconnect indicator on the stimulator. And check the setting of amplitude and impulse duration. Check the stimulator settings. And if motor response disappears and cannot be regained even after increasing stimulus or amplitude and duration, check for the causes listed previously, and it can be caused by the injection of local anesthetic also. So this is the troubleshooting flow chart. So first use a nerve stimulator and put the settings of 0.5 milliamperes as the current intensity, 0.1 milliseconds as pulse width, and 2 hertz as a frequency. And then advance needle towards the plexus. So when adequate needle placement observed with ultrasound, if there is a motor response, withdraw or reposition needle to ensure no motor response at 0.5 milliamperes. Then 1 to 2 ml of injection of local anesthetic results in adequate spread in the desired tissue plane. And the opening injection pressure should be normal, which is it should be less than 15 psig. And the injection is completed. And if there is no motor response, but there is a adequate needle placement observed with ultrasound, it is not necessary to look for a muscle response. You can directly give the drug under the ultrasound guidance visualization. And if the needle placement is not clear by the ultrasound and the imaging is difficult and there is a motor response, then you can give the drug. But if there is no motor response, and then try to adjust the needle placement by ultrasound and also increase the current to 1.5 milliamperes until the motor response is seen. This is a study on which a peripheral nerve stimulation under ultrasonographic control to determine the needle to nerve relationship. The results showed that the needle to needle distances were greater when muscle response was obtained with 2 milliamperes than with 1 and 0.5 milliamperes at 0.1 and 0.3 milliseconds. So it says that there is no significant differences was observed between the needle to nerve distances by using pulse width of 0.1 or 0.3 milliseconds. And there is another study done on opening injection pressure consistently detects needle nerve contact during ultrasound guided interscalene brachial plexus block and the results were like this. So 15 patient has at least one clearly visible route, and opening injection pressure at 1 mm distance from the nerve was less than 15 psig, and 1 ml of injection could be completed in all but two cases. In contrast, opening injection pressure during needle nerve contact was 15 psig or greater in 35 of 36 injections. So this prevented the injection of local anesthetic in such cases. So my references are these. Thank you.
Dr. Radhika, can you share your PPT?
Yes, ma'am. Yes, ma'am. Is my screen audible?
Yeah, it's visible.
Yes, ma'am. Good evening to one and all. I'm Dr. Radhika Ganesh, and my topic for today is limitations and pitfalls of PNS. I am a fellow at Children's Anesthesia Services, Mumbai, under Dr. Vishali Ponde ma'am and Dr. Ankit Desai sir. 1 second, ma'am. Yeah. So peripheral nerve stimulator remains a valuable tool for nerve localization and performing a peripheral nerve block. But despite this, there are various limitations that are associated with their day-to-day use that can impact the block reliability, effect and the safety and accuracy. So in this discussion, we will discuss regarding the limitations and pitfalls that are associated with PNS-guided nerve blocks. Coming to patient discomfort, as PNS requires delivery of an electric current to elicit a motor response, it can sometimes lead to patient discomfort or pain, which is seen in awake or lightly sedated patients. Even repeated needle adjustments and incremental increases in stimulating current causes unpleasant muscle contractions, paresthesia, or anxiety, and thereby it reduces the patient cooperation. It can therefore also affect the overall block quality and patient cooperation. Coming to false positives, as we all know, PNS relies on motor responses as an indirect indicator of needle nerve proximity. As it is an indirect measure, it can many a times lead to false interpretation. And there are instances where motor responses are elicited despite the needle tip being in an unsafe or non-optimal location. The examples of this are direct muscle stimulation, spread of current through the surrounding tissues, and intraneural needle placement. Coming to false negatives, generally, as we have all observed and studied, a motor response at a current amplitude of 0.3 to 0.5 milliamperes generally confirms a close proximity to the nerve to be blocked. And a motor response at less than 0.2 milliampere poses a risk of intraneural placement of the needle. But there are certain conditions in which absence of motor responses does not exclude close proximity or intraneural needle placement. The various examples to this are neuropathy or reduced nerve excitability, the deep blocks requiring higher current, patient on muscle relaxation, and poor tissue conductivity or anatomical variation. The following article studied patients receiving popliteal sciatic nerve block for foot or ankle surgery. The endpoint for needle advancement was predetermined to be either an elicited motor response between 0.2 to 0.5 milliamperes or an apparent intraneural location as seen on ultrasound. The result was that elicited motor response could be obtained only upon entry of the needle into the intraneural space in 20 patients, and in the remaining 4 patients, a motor response with a stimulating current of 1.5 milliamperes could not be obtained even if the needle was entered into the intraneural space. It was concluded that the absence of motor response to nerve stimulation during popliteal block does not exclude an intraneural needle placement and may lead to additional unnecessary attempts at nerve localization. There was this one more study which was done particularly in diabetic neuropathy, but there were also a control group which included non-diabetic patients. There were various studies which were that were conducted to check if the patient had diabetic neuropathy, like the ankle test and everything. And the findings of this study suggested that stimulation thresholds
of 0.3 to 0.5 milliampere may not reliably determine whether there is a closed needle nerve contact during popliteal sciatic nerve block, and this is particular in patients with diabetic neuropathy. Coming to disappearance of motor response after initial injection. The local anesthetics block the voltage-gated sodium channels as soon as they are injected. So this prevents the generation and further propagation of action potential. As the electrical stimulation no longer reaches the muscle twitch disappears. As a result, the PNS can no longer confirm the needle-nerve relationship, any intraneural migration of the needle, and it also creates a false reassurance that the needle position is safe. Coming to anatomical dependency, PNS accuracy is highly operator and anatomy dependent and helps in indirect localization of the nerve. And the motor response to a certain nerve block depends on intact and consistent nerve-muscle pathways. But in case of anatomical variations, there might be unexpected muscle twitches and absent or misleading responses. And in case of deep or overlapping innervations, there might be some non-specific motor responses which can come in the way of our nerve block using PNS. And even the surrounding structures like fascia, fat, and edema alter current spread to a certain extent and can reduce the precision. Coming to miscellaneous drawbacks, PNS nerve block needs an equipment to be set up like a nerve stimulator and insulated needles, and it also requires equipment maintenance and multitasking during nerve blocks. So multitasking means the operator needs to monitor the patient, physiological parameters, response to nerve stimulation, and functionality of nerve stimulator. Although no inference has been conducted, PNS can interfere with pacemakers or other implanted electronic devices. In these cases, it is recommended that placing the nerve stimulator electrode away from the pacemaker components decreases the possibility that the PNS current traverses these components. Coming to an important discussion, that is a peripheral nerve stimulator versus ultrasound for a nerve block. The various properties already discussed with PNS are an indirect localization of the nerve which is done by the PNS. The needle advancement is blind. The LA spread is not seen with the naked eye and can also only be inferred with the motor response. There is a variable success rate. A higher volume of LA is required as the needle and the nerve are not visualized directly. It highly depends on the motor response, and it is limited in patients with neuropathy and receiving muscle relaxation. And also, it is more time consuming as compared to USG, as there is no direct visualization of the nerve. Coming to the features of USG, there is direct needle visualization. Real-time needle tracking can be done. The local anesthetic spread is seen directly with the naked eye. There is higher success rate as compared to the PNS. Lower LA volume is required as compared to PNS, as the nerve spread, the drug spread is seen directly with the naked eye. Improved safety, and it is particularly useful in pediatrics, in patients receiving muscle relaxation and patients with altered anatomy. And it is also faster as compared to PNS. So the following article studied ultrasound guided versus peripheral nerve guided supraclavicular brachial plexus injury for elective upper limb surgery. This was an observational study which concluded that for supraclavicular blocks, USG shortened the execution time and hastened motor blockade while maintaining a high success rate and safety profile. There was also an article which studied the role of peripheral nerve stimulation in the area of USG guided regional anesthesia. In the study, it conferred that USG conferred an 84% relative risk reduction for vascular puncture compared with nerve stimulation, and it showed that nerve localization with ultrasound as compared with electrical stimulation significantly increased the block success rate, that is 91.8% with USG versus 82.8% with 91 versus 82.8% by using PNS, and it also decreased pain during the procedure as well as the need for rescue analgesia or anesthesia. There was also an article which studied the adverse outcomes associated with stimulation-based peripheral nerve blocks with or versus without ultrasound. The results were that high definition ultrasonography offered potential advantages in the administration of block. The significant difference in major local anesthesia toxicity supported the use of USG guidance in conjunction with peripheral nerve stimulator to provide peripheral nerve block in an academic anesthesia practice. There was also one more study which compared USG and peripheral nerve stimulator for performing brachial plexus block, which concluded that USG guided supraclavicular brachial plexus block was quick to perform, improved the patient's safety, and ensured good quality of block, and was accurate in identifying the position of the nerves to be blocked. To conclude, my take home message would be PNS will always be an indirect indicator of muscle block. There would be no visualization of the nerve or spread of the injectable. It is highly anatomy dependent. It has a lower safety margin as compared to USG, and also time consuming as compared to USG. So my take home message would be, if there is availability of both USG and PNS in a setting, a combination of these two techniques for performing a nerve block would be ideal. These are my references. Thank you.
Congratulations to all the speakers. However, we have anybody for question? Otherwise, we have a few questions.
Ma'am, please go ahead.
I don't know which of the second speaker, I think you were showing the nerve block. Now, all of y'all have mentioned, you mentioned the mapping needle.
Yes,
Has
ma'am.
anybody seen where it's being used or how it's being used? Any of y'all, the three speakers?
Ma'am, we did not practice giving a block using a nerve mapping technique, but we tried to do the nerve mapping on the patient, but we did not actually perform the block.
Right. So for anesthesia practice, basically it is to identify, in how close or how much to basically localize and minimize the distance or the area in which you need to block. However, it's more rampantly used in our ER by our plastic surgeons and other surgeons, where a patient comes with trauma, they will need to identify the intact nerves by mapping the nerves, and they try to see if there has been a severance of the nerves. So there they often use it. We have used it and demonstrated for our students. It's quite painful actually when you have to do it transcutaneous when you're awake. That is one of the questions. Secondly, there is a continuous catheterization technique when we use along with the nerve stimulation. I wish the first speaker Manjesh had presented needle in catheter versus catheter in needle pictures, to demonstrate the type of needles. Then the blunt, short bevel tip versus long bevel tip needles. That would have helped to show the type of different nerve stimulators. Now, does it matter if when we keep the anode electrode, proximal or distal to the nerve block, and how far the distance is of the anode electrode from the area of stimulation? Anybody?
Ma'am, it can be anywhere as long as a circuit is complete, ma'am. But for lower limb blocks, you can place it on the other limb as well. But for upper limb block, as a current transmits through the heart, we are not supposed to put the positive electrode on the other limb.
Okay.
You will also be limited by the length of the wire on
Yes,
the
ma'am.
stimulating electrodes. It can't be too far anyway.
Any take on stimulating catheters? Any comment? Has anybody any one of you have ever used stimulating catheters?
I have not used, ma'am.
Okay.
In our institute, we have, but they are catheter into the needles. We don't have
over the
needles.
Catheters. Yeah, because Aora says stimulating catheters are sort of obsolete now, with good visualization of the ultrasound guided drug spread. So I just was curious whether anybody is still using stimulating catheters.
I do agree about the current, what she mentioned in diabetics. In fact, last week we had a patient who had to be exclusively done under sciatic and femoral block. He
Yes.
came twice for the procedure. Even at 1.5 milliampere current, we could not elicit any motor response. However, on ultrasound, we knew we were in the sciatic between the connective tissue, and we went ahead with the block, and it was successful. So yes, those are the limiting factors. However, motor response was there into the muscles, and when you increase the current, but we didn't want him to be affected by the high current. So even at 1.5, it could not elicit any, though it was very close into the sheath. We could not elicit any response.
Yeah, true. That is the reason why dual modality is advised whenever there is a limiting factor. I mean, the neuropathies and all. It's better to have an ultrasound, definitely. Yeah. Another, it's a simple question. Since we have been discussing the peripheral nerve stimulator, how many of you have ever read what is the ideal muscle response for seen for the particular blocks?
Yes, ma'am.
Have you been reading all those things also?
Yes, ma'am. For interscalene block, there should be deltoid contraction or shoulder abduction because of stimulation of axillary nerve. And for supraclavicular brachial plexus block, it should be either a hand or finger flexion or extension. And same for the infraclavicular brachial plexus block also, ma'am. And for median nerve, it should be wrist flexion and thumb index finger flexion. And for ulnar nerve, it should be finger abduction or adduction, and also ulnar deviation can also be elicited. And for radial nerve, it should be wrist and finger extension. And sciatic nerve, it is plantar flexion or foot or dorsiflexion.
So which will you prefer, plantar flexion or dorsiflexion?
Dorsiflexion, ma'am.
The
So what
best
are you?
response would be plantar flexion, I think, for tibial nerve.
It's
Yes,
plantar flexion
TBL.
for the
Yes, ma'am.
child.
Okay.
Correct. Plantar. Okay, I'm happy at least you are reading, because your batch. I don't think you are doing exclusive PNS guided blocks, isn't it?
Yes,
During,
ma'am.
yeah, but it's good to know this what we have just discussed. You have to know these things.
Yeah.
Good.
Thank
So,
you, ma'am.
Meera, the only question, the problem was with your video, because it was not done properly. So now you have just talked about it, that when you are doing the shoulder block, you need to see the deltoid, the interscalene block. You should be seeing that.
Yes, ma'am.
So all
In my
those, whenever you are doing shooting a video, you should be very careful and do it properly. Otherwise, your presentations was good, very nice.
Thank you,
All
ma'am.
the presentations, you have read a lot, all three of you, very nicely done.
Thank you, ma'am.
Thank you, ma'am.
Any questions from mentors? Any other mentors?
I just want to say, add to you saying that all spoke clearly and confidently. It was a pleasure to listen to all three of them. None of them were reading from the slides. Slides were readable. Content was very good. So I think that's a job well done for all three. Just a few things, clarifications only. This is from Manjesh. Manjesh, I just wanted to, I know you know what you're saying.
Yes,
Can you
ma'am.
just say what is a chronaxi and what is a Rio base?
Ma'am, Rio base is the minimum current required to elicit a response, whereas chronaxi is the duration, like that is twice the minimum current that is used for a particular duration to
What
elicit
would
this.
be the unit for chronaxi then, if it's duration?
I didn't get your question, ma'am.
What would be the unit for chronaxi?
What are you measuring?
Like
When
the
you
time
say
in
duration,
milliseconds.
what is it?
Time in milliseconds, ma'am.
Okay, so you had some confusion there about chronaxi. That's why I asked you that question. Yeah, the pulse duration needed to
Pulse.
elicit a response, right?
Yes,
The
ma'am.
duration would be in milliseconds. Okay.
Yes, ma'am.
All right. Okay. So I think you said in your presentation at one point you said current. That's why I asked you that question.
Okay.
No problem.
Uh,
I find it easy to remember when you say cathode, negative, and needle. CNN is an easy mnemonic to remember. Cathode, nerve, and needle.
Okay.
Cathode, negative, and needle. Okay.
Yes, ma'am.
These are small things. When you write units, you must use the scientific units as they are mentioned in scientific literature. So when you write milliamperes, M should be small, A should be capital. Hertz is H capital, Z is small, and things like that. And when you write, say, some 0.2 milliamperes, there should be a space between 0.2 and milliamperes. So it's just small things to improve your presentations. That's all. Regarding monitoring during blocks, it's very important to say that never cut corners. Anyway, people think I'm using ultrasound, I can see what I'm doing, and then might just do a block with pulse oximeters only on the patient, not have your emergency drugs available, your airway equipment available, and all that. So that is not a good idea. So it's very important to be prepared for the worst, prepared for any critical events, because they don't tell you when they're going to happen. And when they happen, you have to be ready for that. And that's why you're trained so much. So never cut corners. Don't depend entirely on the ultrasound or aspiration. You must have things ready for your critical incident management. Um, I think it was Meera who said something about initial injection has to be done slowly. I think every injection, the entire injection has to be done slowly. In fact, I think all of you must be practicing that also. Every 2-3 ml, you aspirate, repeated aspirations and injection, aspiration, injection. It has to be done slowly, not only because
Yes, ma'am.
your needle may move, also the injection pressure is important. So you're seeing ultrasound, you're looking at the peripheral nerve stimulator, but you don't know what pressure you're injecting at. And that pressure can increase with your speed of injection. So it's very important to inject slowly. And I'm sure you've seen the literature where even an intraneural injection may not harm, provided the pressure is less than, injection pressure is less than 15 psi. So, whereas if the pressure is high, even perineural injections can be harmful, can cause nerve injury. So that's very important. You're sticking to those kind of basics. I just wanted to ask Meera, what was your frequency of stimulation when you did the that video, that case?
It was around 5 hertz, ma'am.
Oh, okay, right. I think
Yeah.
usually
Yeah,
it was
it should
quite
be.
fast. Yeah.
Yes, yes,
So
yes.
that can be uncomfortable for the patient. So 1 hertz may be a little too slow. 2 hertz probably okay. 3 hertz is still all right, especially if you're using sense. I have not used sense, but beyond that, I think can become uncomfortable for the patient.
Yes, ma'am.
Yeah.
Yes.
Yeah. Just another
Anybody?
tip.
Yeah. No, you
Anybody
continue.
using?
Sensi of HNS12 stimulator, Sensi mode.
We haven't used the Sensi mode.
No, ma'am.
No, none of you. It's a wonderful technique. It's a wonderful technique. You should mention Sensi technique when you are doing the talking about the principles and of PNS. It's a wonderful technique. It gives you three stimulations in a sequence. The first two are smaller duration, and the third one is a longer duration. And usually, it gives you a very. It warns you when you are reaching the nerve, but you are still at a far distance. So the first prick success rate is very high with Sensi. It's wonderful.
Hi, this is Dr. Pallari here.
Yes.
Yeah,
Yes,
just
sir.
wanted to add something about the PNS guided response to the sciatic nerve. Out of dorsiflexion and plantar flexion obviously would be better one because that is the tibial component. But the best response for that would be the inversion. Because we need tibialis anterior as well as tibialis posterior contraction for inversion. that we get when your needle, if you are doing it with the PNS guided, is exactly inside the paraneural sheath and inside between the tibialis, between both. I mean, yeah, tibial nerve as well as the common peroneal nerve. So that would be the best response. That is the inversion.
That's correct, sir.
Yeah.
Any queries from fellows? So there's a question from Dr. Rajaram Prabhu, respected faculty. The insulated needle used has a blunt tip, if I'm not wrong. If I'm not wrong, what would be the risk of nerve injury using such needles, warranting the use of nerve stimulation for safety?
Anyone from the presenter want to answer it?
So we can still take the aid of the muscle response at the current, right? Depending on what response we are getting at the specific current, like 0.5 milliampere.
I think question is regarding
the question-
what if you use sharp needle, sharp edge needle or short bevel needle, or what is the difference? Like if you are using hypodermic needle and if you are using regular block needles, what is the difference in nerve injury? Any of the presenters want to answer, or any other fellow? Which is safe? Long bevel or short bevel? Hello?
Sir, can I answer?
Yeah, Aishwarya, you can answer it.
So, if you're using a sharp bevel needle, if you're comparing sharp bevel with a blunt bevel, so if you're using a sharp bevel, the chances of injury to the nerve will be more compared to a blunt bevel. But if, in case, suppose a nerve injury occurs, then the damage produced by the sharp bevel will be less, like compared to the blunt bevel, because it's like the dent created will be less if you're using a hypodermic sharp.
Yes, that is the perfect answer. So if you are using a sharp needle, the chances of penetration of the nerve is more as compared to short bevel needle. But once you pierce the nerve, damage done by the short bevel needle is more as compared to sharp needle. So that's why PNS is important. If you are getting stimulation at 0.2 milliamps or 0.3 milliamps, there are chances that you are inside the neural tissue and you can cause the damage. So be careful if you are once you get the response at 1 or 1.5 milliamps, reduce the current to 0.5 milliamps, then go up to 0.2 milliamps. And if you are getting the response, then you have to withdraw the needle to prevent a nerve injury. And if you inject there, then there are chances of nerve injury.
So, Dr. Radhika, can you tell us how we can identify the needle position, whether it's intra or perineural, different ways? We mentioned PNS, isn't it? Any other way of knowing it?
Ma'am, through PNS?
Yes, PNS is one. We just
Yes,
mentioned that, isn't it? Any other method?
Ma'am,
Other
in
than
the studies that were conducted, the studies that were mentioned, the video was recorded while injecting the drug and the spread of the drug, and it was studied. So that is one way of seeing whether the spread is happening intraneurally or perineurally. So that might be one
you
of
mean
the.
you look at the ultrasound and decide, is it? That's what you're saying?
Yes, ma'am. And even there is also presence of injection pressure monitors nowadays.
Yes.
So that can be used. That can be attached to the peripheral nerve stimulator, and if the pressure is more than 15 psi, then the injection pressure is more than 15 psi, it won't inject. So by that we can know that the needle has gone intraneurally. So we need to withdraw the needle.
Very good. Any other mention in the literature? I'm not familiar with the actual procedure. I've only read about it. Are you aware of any other method? Have you heard of impedance measurement?
Yes, ma'am.
Yes.
So the impedance, by using impedance monitor, we can see which we can check for any intravascular injection of the drug. So once the drug, we can use I've read in the study that you can use a dextrose or something to inject. So if it is the impedance is decreasing, that means that it is in the intravascular compartment. So we need to see the baseline impedance before performing the block. So if the the impedance has decreased as compared to the baseline, then it might be injected into the intravascular compartment.
The
And if it is in
question was intraneural versus perineural.
yes, ma'am.
Impedance measurement. The
Yes, ma'am.
impedance would
So
be
impedance, if it is in the intraneural compartment, the impedance will rise very highly
much
as
more.
compared to the baseline versus
Correct.
the perineural compartment, ma'am.
Correct.
But I've
I
never
have,
seen it. I've just read.
neither have I. Neither have I. Yes. Have you
Yeah,
heard of CAIT technique?
since you mentioned that dextrose, there's one more query. Now, when we used for hydrodissection initially to know, what would be your choice of whether it's a saline you would want to use or a 5% dextrose or distilled water, and why?
Yes, ma'am. If we use normal saline, it is a conductor of electricity. So once we inject normal saline, the current will be dispersed in various directions. So the muscle response will disappear. So we will not know whether the needle position is in the same position as we have seen previously or it has migrated. But if we use 5% dextrose, it is not a conductor of electricity. So even if we inject it, there will be presence of muscle twitches. So if after injecting dextrose, if the muscle twitches disappear, that means the needle has definitely migrated because it is not a conductor of electricity.
So it is more used at while pacing the, perineural catheters, because once you inject the, drug or saline, your response will go away. So if you want to put stimulating catheter, you should inject dextrose rather than injecting normal saline or local anesthetic drug, right?
Yes, sir.
And Radhika, at your place, what do you practice? Like, do you practice triple monitoring, injection pressure monitor, PNS, and ultrasound, or you are using double technique or single only, ultrasound only?
So most of the time we use just a USG guided block, but
Okay.
in certain cases, actually we mainly practice pediatrics, so we mainly use USG guided blocks. But sometimes we use USG combined with PNS.
In which blocks? In which blocks?
So I've used it in PNS guided blocks. I've used it in adductor canal blocks, sir.
Adductor canal, why?
I've used it once, sir.
For which response? For stimulating which nerve?
As a nerve to vastus medialis, as the
Good,
saphenous
good.
nerve is
Are you using
purely-
very good. Are you using it for sciatic nerve?
No, sir. The saphenous nerve is a purely.
No, sciatic nerve.
Sorry, sir. Huh?
Are you using it for sciatic nerve?
I've mainly used USG only, sir. Not much of PNS for sciatic.
So, when you are using only USG, what care will you take to prevent nerve injury?
So if we are using only USG, we should make sure that the injector, while injecting, proper aspiration and the injection pressure should be seen. We don't have a pressure monitoring but we should make sure that the pressure is adequate and the flow of the injectable is free so that it.
So do
we are
you
not
inject yourself, or you ask someone like assistant to inject the
No,
drug?
sir. We usually I inject it myself, or if I have a fellow colleague or any senior, then either they inject or
Very
never
good, very
tell
good.
a technician.
That's what I. Any other questions?
Must say,
Radhika,
Radhika, you are very confident and you speak very well. It's a good attribute.
Thank you, ma'am.
Radhika, you were talking about injection of with sir. You were discussing on 5% dextrose and saline and LA. Can
Yes,
you
ma'am.
name what it is? Which test it is called?
Uh, uh, it's Shui test, I think, ma'am.
No.
No.
Anyone knows?
Yeah, Prerna
Yeah.
has responded. Raj
Yes.
test.
Okay, the
Aishwarya.
Yeah.
okay.
Yeah, yeah. It's okay. It's okay.
And Aishwarya has written about CAI technique also. What is CAI technique, Radhika?
I'm not sure, ma'am.
Okay, what is it, Aishwarya? Are you?
Yes, ma'am. So, ma'am, it's like one of the objective technique to identify the intraneural injection. So, the CAI stands for, ma'am, compressed air injection. So, it's based on the Boyle's law. That is, at a constant temperature, pressure is inversely related to volume. So, in a syringe, we'll take the local anesthetic and we'll take the air. So, when we are doing compression, like suppose if we have compressed the syringe 50%, so at a 50% compression, the pressure will be approximately 760 mm Hg, ma'am. So this pressure, 760 mm Hg, is way below the pressure which will cause injury. So when we are injecting, we'll just have to make sure that the compression is always 50%. So here the local anesthetic is delivered with a constant pressure.
Compression of what at 50%?
Air, ma'am, the air above
Air.
the local anesthetic.
Have you done
How
it?
much? How much volume? What volume of syringe and what volume of drug and air you use in this?
Ma'am, I personally have not done it. I've just read about it. So, ma'am, like practically, I'm not done. I just know the theoretical part of it, ma'am.
All right. Okay.
We generally practice, ma'am, USG or PNS. The only thing.
The article on this actually said they used 10 ml of air and 10 ml of solution in a 20 ml syringe, and they would not compress beyond 5 ml of air. That's what they said. But I tried it and I didn't find it very user friendly. It was didn't like it. So yeah, but that's one more technique that is mentioned.
Any other questions? Any queries from fellows? Hetu sir, shall we move to the quiz part? Bharti ma'am, shall we
Yes.
move?
Yes, please go ahead.
Yes, yes. So we will move
Go
to the
ahead.
quiz now. It will be okay if faculties can, if you want to exit, you can very well leave the class, ma'am. We'll just continue the MCQ with the fellows.
Yeah. Thank you,
Thank you to
Sangamitra.
all the presenters. Only thing again, one thing was when we're using peripheral nerve stimulator, the guidelines for thrombolysis, thrombolytic
Go there.
therapies and everything, we have to keep a watch on the same parameters apply.
Right, ma'am.
Chalo. Thanks a lot. It was wonderful discussion, and all the best to all the fellows.
Thank you, ma'am.
Thank you, ma'am. Thank you for joining today, ma'am.
Dr. Deepak has asked a question, I think, on anodic stimulation example.
Yeah, what is the example for anodic stimulation? Any takers? Acha, sir has already. Deep brain simulation. Thank you, Deepak sir. So shall I move to the quiz now, fellows?
Yes, please. Thank you, Sangamitra. Good night.
Thank you. Thank you. Good night, sir.
Thank you, Sangamitra and Shruti.
Thank
Very
you,
nice
sir.
to conduct. And all the speakers, very well spoken.
Thank you.
Yes.
Thank you, ma'am.
Thank you, Sangamitra.
Thank you, ma'am. Bharti ma'am. Thank you so much. Thank you for joining. So, fellows, you can scan and you can join, or you can use the game pin to join the Kahoot quiz. Please use your full names. Please don't use Pushpa and Terminator. It becomes very difficult for me to know who has won the quiz.